about the properties of the stent.
Thank you.
Dora?
Yes, yes, I hear you. You hear me? Dr. Neymeyer, you hear me?
Dr. Neymeyer, do you want Doron to pass this presentation?
Yes, no. Then Doran can say it then also later. There's no problem. Then we make it on top. We have a lot of questions last time, how we can use a stent really simple for stenosis and for daily work, not only for complication management. Let us first start with a typical case. It's a prostate cancer case after salvage radiotherapy, after strictures, after radiotherapy, and also some fistula. He had a stent before inside it, and the stent, he has not feeling well with the stent, so he wants to get the ileum stent. Now to the inserting. This is really simple and easy, and I show it then really step by step at the end of that 6 cases. First, if you go inside, you go with a guide wire inside. I prefer a soft tip Terumo stent, go inside, and then we have the chance to show the ureter. Next, we go with the ileum inside it. And the interesting part, what you see it, you can bring the stent really simple inside in the Seldinger technique. To the techniques and what is important for you, this is what I want to show you at the next pictures then. Important is, if you see it here, never I go with, if I insert the ileum inside, I do it with a scope. I go every time side by side. You see it, the tip of the cystoscope is nearby the stent. I see it before the ostium. And what I do is, what you see here, really exact on that point. I show now the marker, the laser pointer. You see it here, that I start, if I bring the stent inside, higher to bring it up inside of the stent, and at the end, I can make a good position nearby to the ostium, what I want. This is a distal stenosis and a fistula, both are closed and all is okay. The important thing is, where we have a problem, is the tip of the stent. This is on top here, because this is the size of 8 Shire, and the dilatation must be so big that if you put the stent on the right position, you go later with a tip on the stent through without any dislocation. This is important. The biggest question on last time, we have more than 30 questions about what I can use it, not in a way like a typical urologist can do it, a stent every time inside of. We have now 3 conduit cases. You can put it inside. This is a conduit after cystectomy, but only with one single hydronephrosis on one side. She had a stenosis in the deep one. First, it is really recommended, if you go inside, you have the problem, you have to cover then the stenosis part, really exact. If you have only one kidney, you can use then only a short ileum stent, 12 centimeter stent. This is then enough. If you have then a double kidney, then you had a problem, then you, in these cases, you saw it, we put a stent inside 12 centimeters, the stenosis are covered, it's only one stenosis on the conduit, no problem, the hydronephrosis is gone, all is okay, and the ureter is in a good position and all is okay. If you have 2 kidney and 1 anastomosis, then we prefer in our hospital, and I preferred to make a Wallace anastomosis. Then we have a problem to put only one stent inside, because if I put one stent inside, the ureter both comes together and one side then get obstruction. So if you have a problem with a Wallace anastomosis, you have to put 2 stents side by side inside. This is important. And if you go back, then it is important, if you go inside with a stent and you have a guide wire inside, don't do it that you put on the one side guide wire inside and put then the stent on the inside. If you have one kidney, you can use only one guide wire and all it's okay. But if you have 2 kidneys and a Wallace anastomosis, you have to bring inside both guide wire and then to put both stents on both sides straight inside, and at the end you open the cover sheet and then all it's okay. Otherwise you will dislocate it one stent with the other one. So start with 2 stents, bring it inside and then open it simultaneously side by side, and it will be fixed in the anastomosis pad and all it's okay. So it looks like here, you see it, the stents looks near to the kidney pelvis, really nice, and both comes together and all it's okay, and it looks very well. And you see it here, stent by stent, side by side, all it's okay. Important is, you have never the chance to bring it back. So if you bring the cover back, and you see it here on the kidney, leave 1 centimeter of the head of the stent inside of the kidney pelvis. This is really important. Otherwise, you get a kinking on the top and the stent can be kinked, and then it is not a good idea. You can get a hydronephrosis if you had also a pleural junction problem in this part. Half a centimeter looks inside, this is enough, but not too much, and then go back simultaneously and all is okay. If you have a Mainz pouch, then we go mostly antegrade, not antegrade inside. In this case, you see it here, there's a stone inside it. We have here the nephrostoma before inside it, and then we go with a guide wire in it and bring the stone back and replace the stenosis to the Mainz pouch. And you can go also straight back on top, but you need then not a soft tirumu, you need then a strong guide wire, because you curve with the stand around. And the same idea, what we do now, like we start with the kidney, we start then to open it inside of the pouch. You can go then straight back if you are inside it, then to go then with the tip, what you see here, of the end of the stent, the starting point, because now it's back-sided, antegrade inserted, then you need 1 or 2 centimeters inside, there's a stenosis, and then you leave the stent inside, all it's okay, and it looks very well.
Dr. Neymeyer, just a second, please. I think if I may, if you think it's okay, if we can pass for 5 minutes to Doron to start with the basic of the system. So when the guys see the X-ray, they will understand everything Doron, that they see.
Yes.
This is one thing. And another thing is that you have some annotation, red ones on your screen. You should clear them.
Sorry.
Okay.
Yes.
Stop sharing and pass so Doron can share his presentation. This will be, we made a very short, like 5-6 slides on the delivery system and the stent itself. So when you will see the X-rays, you will understand exactly where are the markers, what are you seeing versus in the system or the stent itself. That will be then easier to follow Dr. Neymeyer's explanation. Doron, please.
Okay, you see my screen now?
Yeah, we do.
Okay, so some key features and advantages for allium stents for the URS. So as you can see, the most important advantages is it's very easy to place. It's self-extendable stent with radiopaque markers, as you will see in the after that. It's a fully covered stent with covered by silicone and polymer, which prevent the tissue ingrowth, as well as the reduced incrustation, stone formation, and classification. The stent is very flexible to ensure minimal irritation and maximum patient comfort. All of Allium stent are approved for CE up to 3 years. Safe removal, we have a backup mechanism of unraveling. We'll explain you this, we'll see. And some of the stents are equipped with an anchor to reduce the chance for migration. You see here the delivery system, it's 80 centimeter long, 10 French, and the stent is crimped in the edge here. Okay, we have Y connector. You need to flush the system before you insert it over the guide wire. You have the markers on the delivery and on the stent for better visualization under fluoroscopy. You see here the stent with an anchor. Every stent has 6 radiopaque markers, 3 each side. And if it's a stent with an anchor, you have an additional 1. And on the delivery system, you have the radiopaque marker ring on the tip. And here you have another 2 that covers the black and the yellow markers, which is a visualization marker through the cystoscope. And here you can see it under X-ray.
Doron, just a second. Go back, please. 1 slide.
Yeah.
This is very important for you to understand the slides that Dr. Neymeyer shows. So when you open the stent, you will have 3 points of the markers on each side. When the stent is closed and crimped, what you will see is the marker on the tip, then another 1 point because the markers will be crimped. Then you can see only 1 point on the screen, and then you will see at the middle the back side of the stent. That's another point, and then another 2. That these are the metal markers from the right and the left of the yellow and black point. So when the system is closed and going inside, you see 5 markers. You need to understand what you see on each one of them. And now during the x-rays, we can explain that again. The ones that you knew it probably saw it already in the pictures that Dr. Neymeyer showed. Sorry, please, Dora.
Can you see my mouse?
Yes.
Okay, this is the ring, okay, the tip of the delivery device. So this is show you where are you on the this point should be on the tip of the delivery device. Then when the stent is crimped, before you open the stent, you will see 3 small dots that say that the stent is still closed. When you will open the stent, like in the left side here, you see now, you see that the stent is open. Okay, stenosis. We have 2 ways to mark the stenosis on the screen. The first one, you can take a tape and put on the screen and mark the stenosis after you flush it with contact medium. You can mark the stenosis on the screen with a type, 1 for the high point and then in the lower point. The same like here, you see the stenosis is the middle of the markers, and then you see the stent after it's opening, you see the 3 dots, then the 3 upper points, and then this is the radiopaque ring that goes through the stent when you pull out the delivery device. Again, here we can use the second way to mark it with a marker on the screen. Don't be afraid to mark it. Then you take a pad with alcohol and you clean it. Also, this is good way to mark the stenosis. And here from the left side, you see the stent after when it expands, you see the 3 points of the proximal. This is the ring. When you pull out after you open the stent and you wait 3 to 4 minutes let the stent to expand, you need to pull out the delivery device. You do it under fluoroscopy to see that the ring of the delivery device is going through the stent, and you don't pull out the stent with the delivery device together. So you need to follow this marker and to see that it's go down through the stent. As we said, we have two versions of stent, one with an anchor and an anchorless. If you use the stent with an anchor, it's only for the lower ureter only. In this way, you place the stent in the lower part, and then you leave the anchor in the bladder. The second one, the anchorless stent, is fit for the lower, for the mid, and for the upper, also including the UPJ strictures. Okay, this is a picture when you, after opening, this is the view. You can go with a thin cystoscope or nephroscope, and you can see from the inside of the ureter how it looked like. About the removal, the stents are very safe to place and very easy to remove. You can grab the stent in any time. You just need to take alligator grasper and catch the stent in the anchor or in the edge of the stent if it's anchorless, and then pull out the cystoscope together with the alligator grasper. In most of the cases, the stent is just slide out very easily. But in case of you will force out more than 1.5 kilo and there is a high resistance, you will feel it. The stent will start to unravel, okay, like a strip in one piece like you see here, but only the first few lines, and then slide out. So it's very simple and non-traumatic. It's just a backup mechanism. It means that in most cases, the stents just slide out very easily. Okay, we can go back to Dr. Neymeyer presentation. Dr. Neymeyer?
Yes, I'm
Okay.
ready. Okay. I want only to give my screen.
Yeah.
Give me the screen and then.
Yeah, okay.
Yes. Wonderful. Now we are in the same like we want to start. That was a mistake of us that we start first with me and the cases, because we speak before that Doran should start to begin and explain it. That is better. And now it is really important you understand the principles. And I want you to show and to understand how it really works. What you see here, this is a full system. And we have not much troubleshoots. We need only to know some very important things. If you use the stand and if you use a guide wire, please take then a long guide wire, because you have the problem then that normally if you are inside it, you have a length of 24 to 28 centimeters, at female 4 centimeters for the urethra, at male 20 centimeters, and then outside the length of the system is 80 centimeters. Please, if you start, this is good and this is a recommendation of mine, then use a long guide wire, not too short, because otherwise you can lose the guide wire if you are inserted and then you make a mistake. If you use it, use every time the guide wire of 0.3.5 inch. That means it is nearly to 0.9 millimeter. This is the best. And longer one, 150 and higher is better for you. I prefer to use a straight one. This is a good one. Very important is, if you go inside it and you put it inside the ileum set with a guide wire, then sometimes in the midline where the connector can be stopped, you want to put it inside, but it's stopped here. So say to your nurse, like, I do it here, turn the system, and then the guide wire will be falling inside of the right way, and all is okay, and you see it at the end. It's coming now, wonderful. And this is the reason why I say take a long guide wire. Otherwise, you are too short. You concentrate to the stand, and then you lost your guide wire. Please take a good one and turn around, and it will be inside it, and you have no blockade. Secondary, if you want to see also the ureter and also the kidney later with fluid for better position, then you have two chances to do it. If you close the midline part before you open it, or if you are open it, you can close it, and then you can put saline, contrast medium inside, and at the end of the tip, it's coming out. But it's come only where the opening of the cover is opened. So you have a chance also during the treatment of opening to make a good position and a good viewing. Where's your problem? If you want to see the top where you are and to see it better, you can go with a saline at the end. You need only injection, a syringe, and a cannula. You can go at the end, you put the guide wire out, go there, and then you see it. I want to show it here. You can close it. If you close it here, you see it here, the guide wire is inside it. You want to see also to check it, put the line inside it, and at the end you can see also inside of the ureter really sharp. Where is your problem? If you want to see it on top at the end, you take a cannula, take the guide wire outside, and put the line inside. So you have the chance also at the inserted system, you see it here, to make a fluid inside and to see it really carefully. Where is your position? Duran said before, really, really strong. We need to fix it. Where is the position? Where is your point of interest? We can mark it, and then we have the chance also to see it later, also with saline. And I open it here now, and you see it. I can go at the end also to the top, and I can go in the midline to see where the cover is open and all it's okay. Duran said also, you can replace it really simple with a grasper. What we do and what we prefer is, if you go inside of the ureter, take with a grasper one of the edges here. This is important, not to capture the part of the silicon, the litinol, you capture it, whereas also a marking point, there's really strong. You can capture it, you can pull it. Mostly the total stent comes out, otherwise it will be unruffled and all it's okay, no problem. I prefer the rigid one. Now, if you have a problem, if you have a strong ureter, it is such curved, you have no chance to go inside, and you have no grasper to catch it, it is lost inside of the top. We have a trick also to capture our stent to replace it. The trick is also to grasper it with a Fugatti catheter. Fugatti is really simple, it's a simple catheter. What we do is also then to go inside and to capture it. I show it to you. Sorry, I make one slide before. Really important is, if you do a stent inside, that we prefer to use dilatation sets. Simple, easy, and cheap. Dilatation sets is better than balloon. For the deep stenosis, we use only a simple short one. For the longer one, typically ureter catheter. Later, you saw it, what Duran showed, some part of the stenosis, you can measure it also. If you make an X-ray, you can calculate, you can see the curves of the ileum stent, and then you can check it and you can measure it on your X-ray. How long is your stricture, or where is your problem? Two lines are 12 millimeter, one line are 6 millimeter. This is important to see. You see it here, what we can do with the stent. We have two things. One, to cover a stenosis, or to cover also a leakage, like a partial defect, and also we can close also a complete defect. Now it is interesting how it looks like then if you insert it. If you bring the stent inside, it looks not in such a way like it's here. At the end, if you have a big leakage, then the stent get every time the total white, what they have it, if you bring it inside in such a way. The picture looks here, what you see. Doran showed also stricture and stricture. This was the total defect. And here in the midline, you see now the total white of the stent, 9 millimeter. At the end, if you have a stricture or you make also a bridging, you see after 2 to 4 weeks that that part, where is the stricture part, it will be open. The force power of the allium stent, it's low, and it replaces also the strictures, and all it's okay. Really interesting and important for you is you can calculate it later and to see it, and you can see it and measure it also. Now you see what I say before with the Fugatti. It's a trick if you lost also a stent, or if you can't get, and if you have no chance to get a grasper. I go with a Fugatti inside, make a balloon on it, and then it captures the end. It captures the end of the stent, and then you can go inside. It's connect to the stent, and you can pull it also out. This is a chance if you have, for example, a flexible scope, and the kidney is back around, and you have a dislocated, for example, stent to capture it. Fugatti is right, and it's simple and easy. Everybody have it. You can get it from your surgeons. Now we started again. What we say. Doran said it very exact. If you have a case like stricture and, for example, fistula, both is in that case. It was a stricture after radiotherapy, radical prostatectomy in a deep one. And what we do is, this is important, why we say before, make a dilatation. The stricture was in the deepness part of the ureter under the vessel border. You have to dilatate it. This is recommended also from the company to 14 Shire. Otherwise, the tip of the stent, if you bring it later back, can be dislocated also, or can stop in that area here. Please make a dilatation in that area to 14 Shire. If you start and bring the stent inside, start every time higher. That means we want to place it so here at the end of the stent. I start with the stent higher inside it, and I bring it a little down. And what you see here is that inside it also contrast fluid. For better viewing, to better make a position, this was a trick what I say before. If you have no chance, if you have some feeling, you don't know where it is really exact, and your marking on the monitor are not so exact, and you have a feeling, please close the connectors. Please close the connectors here, and then make a saline inside, and you will see it inside of your stent to make a good position where it is. Make it then later a little down, like where is your position of interest, like you see it here, and then you can go with a tip through, and all it's okay. If you have, for example, not a typically case like stenosis, what you have dilated and put a stent inside, or if you bridge also, or you cover a fistula, you have a critically one like a conduit. Conduit was the most questions also like last time. There it is really recommended you take a long guide wire, because with a long guide wire you have a chance not to lose it, because if you have a conduit, most conduit have a length between 10 centimeters, sometimes can be 25 centimeters, and then you can lose then the guide wire inside if you insert your stent. So please take a long one. Go with the guide wire inside, starting high, and then you can replace it. And you can dilatate also the stenosis. In this case, it's really simple. It is a conduit with a stenosis where only the ureter on the left side is connected. Then it looks very well, and you doesn't need to bring the stent till to the conduit. You can leave it only inside in the distal part where the stenosis is. For this one, we use the 12 centimeter stent. If you have a conduit with 2 ureter, this is really problematic, because you can't use only one stent. Because if you use one stent, it will make an obstruction to the other side if you use a Wallace anastomosis. In these cases, we use every time 2 stents if you have a Wallace anastomosis. We start then to put a guide wire on both sides inside. On both sides we put the allium stent, and then we go back bilateral simultaneously, and it looks like what you see in the presentation. Important is that the start, this is what Doran said, really exact. You have to see the marking points. You see it here at the kidney. You have to see the marking points inside of the kidney pelvis, but only 1 centimeter over the pulo junction kidney, because angle. Otherwise, you have a problem. If it's too deep inside, you can get a hydronephrosis because you have a stop on top, or if you are too deep, it can be kinked, and then we have also a problem. Then please bring both inside, then you never will dislocate it, because both stents will be fixed then near to the Wallace anastomosis. They make a kissing phenomenon, they are fixed it, and then it's a good position and all it's okay. You see it here, it's a good fluid, both stents looking side by side. The X-ray marker, you see it here, 1, 2, 3, 1, 2, 3, and on the other side, 1, 2, 3, 1, 2, 3. We use at a conduit every time the ankle is stent, because at conduit we have a chance to go antegrade or retrograde. You see now, these cases are both retrograde or inside it. If you have a Mainz pouch, then we have a problem. We can't go through the bowel inside of the ureter back to the kidney. In these cases, we go antegrade forward through over the nephrostomy. That means in these cases we have a stenosis near to the Mainz pouch, also with a stone there. Then we go antegrade inside it, replace the stone, make a dilatation, the guide wire inside, and you see it here. The stent, it looks very well inside, and the fluid comes through. It's no problem. And you see also a small reflux till there after inserting the stent. Important is that you go over the fixation. In this case, that was a Mainz pouch with a 1 hydronephrosis on one side, and both they had no Wallace anastomosis. They had 2 different anastomoses, and one has a hydronephrosis with a stone and stricture, so we need only 1 stent.
Dr. Neymeyer, Dr. Neymeyer, there is a question from the audience.
Yes.
I want you to stop for a second.
Yes.
Someone asked if, don't you afraid to increase the pressure on the anastomosis when you use 2 stents?
Can you say it again?
Don't you afraid to increase the pressure on anastomosis when you use 2 stents?
No. If you go with 2 stents, they are not pressing together and you have not closing, because the power of the stent is so strong that over the time it will be open. Be careful, because what you see here also on the picture, where is the stenosis? After 2 to 4 weeks, never you will see that stenosis part. Soft opening later with a smooth power on the stenosis, it will be open. The same is if you have it side by side. Both stents are not stopping itself. It will be open. Otherwise, if you use only, like in this case here, if you use in this case only one stent, then you will be making an obstruction on the other side and you have a hydronephrosis on the other side. If you have a Wallace anastomosis, side by side ureter, then you need 2 stents if you have a problem in your anastomosis. If you have a double anastomosis, then you can go only on one side inside and then the other you can leave, because the pressure might not compare to the other side, only in case of Wallace anastomosis. This is really important and also to know. And if you have a stricture like what you see here, you have only to pass the stricture, you have to wait. You see it here, it's a small stricture, it's only one curve. What the stricture is here, only 6 millimeter long. It will be replaced itself after 2 to 4 weeks and all it's okay. But the problem is you have to go in this case, in most cases of Mainz pouch, antegrad inside. Also, if you have a neobladder, go antegrad and not retrograd. It's more comfortable.
Okay,
if
so
you have no chance also to go as a conduit, you see it here also, next conduit case, not to go in a typically antegrad way through the conduit, she's a really fatty lady, then you go from the other side. You see it here, that was the part. There was a hydronephrotic ureter, but what you see here also in that, the conduit was dislocated from the ureter. It was broken because there was a tumor. The tumor at the anastomosis. She had only one kidney on one side. And in this case, you see it here, we go now with a guide wire antegrad from one side inside, and then we put a stent. But we saw before that we have to cover also, because there was here also a fistula, we want to bridge it. And in these cases, we go from one side inside with a guide wire out from the conduit. And what you see here, what we do is we do more than one stent. 1, 2, 3 stents, and the stent looks outside of the conduit totally, and to cover it. You see it here. 1, 2, 3. 1, 2, 3. And so you have now to cover the stenosis, you bridge the tumor necrosis. The ground of the tumor was at the bottom of the conduit. It was totally broken and open. It was a fistula case here, and you can cover it. And in the same moment it is dry, the stent goes through the tumor. And what you see here, all it's open. That was a control check after 2 weeks. Where is the anastomosis, or where is the stricture? The stricture parts of the stents, where is it? Where is it pressed together? What you see of the picture of Doran also before, it will be open itself by the own power. And you see it here. That was a bridge covering part. There was also the tumor. This was the bottom of the conduit with a tumor, and all goes through. And interesting, in CT scan, you see the X-ray marker at the end, the 3 points, like the points here. This was one stent from the kidney to the part of the end of the stenosis. There was the X-ray marker, and you see also the other one, because it's stent over stent, what we do it here, and all it's looking very bad. You see it now? The stricture is open. The stricture is totally open, and the stent goes now through the tumor inside of the conduit, looks out, and you have a real drainage. That was the third opening of the woman before they make a replacement of tumor mass. That was the last chance for her. And you see it here. The stent looks then outside of the conduit. You have a fully drainage from the kidney with 3 stents outside, and we have complete bridged the tumor parts, the necrosis of the ureter. We bridged also, go over the stenosis through the tumor, through the conduit, and bring the ureter outside. Next question was, can we use also allium stent at kidney transplant? This is a patient with a kidney transplant on the right side, and he had also prostate cancer before, small capacity of bladder, and he had a stricture of the ureter. And in these cases, we do also allium stent. This is really good, but we don't use them the 12 centimeters, not the 120 centimeters. We use then the 8 centimeters, because in most cases, most kidney transplant patients have a really short ureter, but you can measure it before. But remember, you need then 1 centimeter to look inside of the kidney pelvis and 1 centimeter then through. But you see here, that was here only the problem of the stenosis in that part. That's why we have to use in that case only 8 centimeters. All was enough and all was good. For kidney transplant, nice part and all it's okay, and you have no problem. Typically case, and this is why we want to discuss it today, how we want to do it. The most mistake is if you use a stent, if you have a pyrolojunction problem, what do you see here? And this lady had 3 problems. She had a cervical cancer before, after radiotherapy with stenosis in both sides under the vessel border. And she had also a stenosis near to the kidney pelvis. In this part, we want to replace all problems because the lady comes every 2 weeks to change the double J. What we do is now, first, what we say before, we make a dilatation to bring a stent inside. We need to dilatate it before, what you see here with 14 Shire. We have to replace the stenosis. Secondary, we go then inside it with the stent over the pyrolojunction part. This is really important. We start higher and can replace it a little deeper. And then at the end, we can bring also for the deep one, in this case, 200 centimeters was not enough. That's why we make an extension. We make a 120 in the deepness, and you see here, there was a stenosis too. Important is, and this is now when you see also if the lady is moving, if you are not deep enough inside of the kidney pelvis, it will be replaced and then it will be stopped itself. On the other side, on the right side, we need only a 200 centimeter stent because she had only a stricture in the deep one. And you see it here. This was the stenosis here. There's also the stenosis. And what we remember before, you can measure now the length. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And what we know now, 6 centimeters on one side, 6 centimeters on the other side. And important is this picture, what you see here now. If the patient is jumping or moving, the kidney is also moving a little. That's why do 1 centimeter of the end of the stent inside of the kidney pelvis. If you are too far inside, then it will be blocked itself. So only 1 centimeter. If you are too deep, it is under the pyrolojunction angle, and then you have a problem. This is important. Remember, we have to dilatate the stenosis before to 14 Shire. This is really important. Then we can bring the stent inside. And now, if I show then also how I open the stent then if I end my presentation really exact. This is important. Dilatate before starting with the stent higher. You can go a little deeper. You can use it for partial defects, for complete defects, and then it's okay. If you have a stenosis, a real stenosis, it is not only recommended to make a dilatation. You replace not your problem. You bring a stent, wonderful inside, all it's okay. But later, if you put it out, the stenosis can become again. In these cases, we cut the stenosis. And the trick is really simple. We use a normal mandrel with the stainless steel inside. We cut only the ends, and what we do now, we go with a typically scope inside. And what we do with energy at the end, and we can cut with the tip of the part. You see it here in the animation. A rigid scope, you go with a ureter catheter inside, you can make then the metal on the top, and then you can cut the stenosis really carefully. It is simple and easy. You see that case. If you make only a dilatation, it is also wonderful. Then you have the treatment with the stent. It's a long life stent. You can leave it for 3 to 5 years, no problem. If you want to replace the stenosis after thermal damage or after stone therapy, then we go inside, we cut straight the stenosis, we don't dilatate it, we cut it with monopolar, with a knife, and the idea is what you see here, you have stenosis, you have to cut it, and then you make it like you create an iatrogenic fistula here, but you cover it with a stent, and then you replace the stenosis really carefully. And what you see here is I cut the stenosis. It was a stenosis. It was a thermal damage after radical lymph node dissection, and I go now through. You see it. I cut it with monopolar under vision, and the stenosis is straight on the iliac crossing, and I go inside, and then I bring at the end the ilium stent inside. And the good is with the monopolar, you can cut and you can make also correlation. You see here a small bleeding, and I can go now straight inside and can make also a correlation. You see the stenosis, I can open it more and more. I go here now, I cut it more and more, and at the end, I bring a stent inside, and all it's okay. This is a picture here, go inside, then through, put the stent, and this part here, whereas the rest stenosis, it will be open itself at the end. After 6 months, you take it out, and all it's okay, and the stent looks very well. You see it here at the end of the procedure, it looks more and more, and all it's okay. And then you bring it out, and it is really simple. So it looks later. If you go with the scope inside, the ureter, it's really fast, wide, and it is not fixed to the ureter wall. You can replace this with a forceps, and all it's okay. I can stop it here, and I want to show, give my face. You see it here, really exact what I mean. Important is, if you put then the stent inside, you see with your eyes every time to the X-ray. And if you want to open it, you have to open it carefully here. And important is, if the stent is on X-ray on the right position, you make in most cases a mistake. You take your hand here, you want to replace it, and then you go higher. That's why fix with your eye every time the point on X-ray of the stent of the tip, and then you see it. I go smoothly, this hand in this direction, my hand in the other direction. I press it inside, and you see it now. I go back, and smoothly and smoothly and smoothly. Now it will be opening the stent. And this part, what you see here, this is important. You see that the tip is 1 centimeter over the ends of the spikes. This is a point what you see really exact, the end of the inserter. This is what you fix with your eyes, and then at the end, if you have a good position there, you open it to the half, not open it totally. You see it here on the half side. Then you have a chance, because here it's fixed, I can take it, it's not replaced. I can go now on the right position down, on the right placement where I want. And Doran said it really exact. Make a marking point on your X-ray where is the point of interest, go then, and then at the end, wait 2 minutes or 3 minutes. I never wait, we have no time, we are Germans. Then we are open, 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 open. And what you see here, if it's at the end open, if it's here outside, if you go here together, then you have no chance, to bring it in the right position. That's why recommendation is make it to the half side, starting higher in the kidney, part, and then you can go a little straight down where you want to make the right position, and then you can bring the stent in the right position, and all it's really okay, and you see it really exact. This is my recommendation. Thanks to Doran and to the participants. What is your questions?
Thank you, Dr. Neymeyer. We have a lot of questions here, but I got this week a question from one distributor that he have a lot of...
Okay, two things, because I see it here.
Okay.
The last questions. Interesting, because this is really impressive. We used the memo cut also before for a long time, and also the metal resonance stent. That are metal stents. And the difference between both stents are, this is a fully covered stent. Never he engrafts of the tissue. You can't replace it. You can replace it. And secondary, that is covering totally, then also fistula, and you can bridging. This is not possible with metal resonance stent and not with MemoCard. The stent is better. And the secondary is, what is better also than the MemoCard? You have here 20 centimeters. You have also 12 or 8 centimeters. If you need more, you can put stent in stent longer and longer, and you can use it also for long distance. This is not possible at MemoCard. MemoCard is the longest time, it's 25 centimeters. So this is a good part to insert. The other question was, you saw it. You can use it also if you have infected patients like tuberculosis, or you have strictures with through or fistulas also with bowel or with a real infection. You can put it inside, it is no problem. We use it since now 9 years, and we never get more infection on top of the ureter. Okay. And for the other one, the questions also for cutting the strictures, we make one special part where we show it really exact. And the last question here on was why we don't need the laser. Laser destroy tissue, and laser it's hot. Then you produce more scar. You cut a scar and produce more scar with the laser. Monopolar is electricity. It's more dangerous. No danger, no fun if you cut it, but it is better. This is not so much scar producing like a laser. This is the reason why for complication management we use monopolar, not laser. Before we use laser, we have bad experience. We stopped laser since the last 8 years, and our experience are better with monopolar. Thanks. Here, how to remove a stent antegrade. you can go. Antegrade, you can go also in the same way. How you put it inside. Put a nephrostomy, go inside, catch it, and go out with the forceps. But if I go antegrade inside, I take not a typically URS, I take a flexible scope, because you can go inside of the kidney to dilate it to 14 Charrière. You go with a flexible scope, you have more working channel, go take a bigger forceps, go through, and all it's okay. Next question.
Dr. Neymeyer, when you decide to remove the stent?
I remove only the stent if I see you have an obstruction again. Obstruction again comes if you have then stones between, it is closed, and then we change it. We know now that's the medium time. What we inserted is good for 3 years. The longest is now 5.5 years. Also, a stone incrustation can be inside of the stent, but we see it less than the other, less than typically double J, or less also of other things. So we change it only in case if it's closed, if you have an obstruction, if you have a retention problem, and the secondary is we bring it out if we make a replacement of a scar or a fistula, then we can take it also out after 2 to 6 months. After 2 months, typically fistula will be closed. If you make a bridging after 6 months, all is closed, and then you can take it also out. But only in benign cases, not in tumor cases.
Did patient have a reflux if you put stent along all of the ureter?
Yes, you saw it also on pictures. You can have also a reflux. That's why we say to the patient, if they had chronic infection in kidney, that they need to go every 2 hours to toilet and bring the urine out and not to wait. This is our recommendation, because if we make a transplant inserting of the ureter, we make it now also without any anti-reflux plastic. This is not a problem, but you have to recommend the patient go every 2 hours to toilet, and then it's no problem. And the doctor asked, Wallace anastomosis with 2 stents do? Yes. Only on C-arm, only 1 arm. If you do only on 1 arm, it's a Wallace, it will be pressed. It is not recommended. It's not a good idea. We done it, and we go now the way in case of a stenosis and Wallace, every time 2 stents, both sides. Next question.
Any experience in case with complete ureteral stricture, not partial, such as complete stenosis due to tuberculosis?
Yes, to tuberculosis. There's a problem is it's a tuberculosis. I make only a cutting of the ureter if I have the idea to replace with a stent later the stenosis and bring the stent out, and then we doesn't need any stent. If we have a fixed tuberculosis, then we have to dilate it, what also Alium said, to 14 Charrière, and then we can bring it inside and we can leave it also, because there's no problem. The tuberculosis part also near to the stent, it's not growing or going on the out cover sheet to the other side. It is fixed there. It is like pressing. It's an area like an area before. You have then to replace it to dilate it, but not then to open it.
No question. Go on and on. Can 20 centimeter stent can be more difficult to remove than the 12 centimeter stent?
No, no. If you take at the end the stent, you can replace it really simple, because what you saw before, you have to catch with the grasper the end, and if it's opening, then you can catch with the latinol on it's coming out. It is no problem to bring it out. And interesting is it, if the stent is inside, the ureter has more diameter and it is not so fixed. If it's leave more than 2 to 4 weeks inside, it is so wide that you will be, in most cases, 90%, you bring the stent totally out. No problem.
I would like to ask you, after you pull out the delivery device, in case you need to relocate the stent again, to reposition, let's say the stenosis, you put the stent, you open the stent proximal to the stenosis, or you put the stent below?
This is a real problem. You have no chance to go up every time you can go down. Otherwise, if you are too deep and you make a misposition, then you can go through the other stent and then go higher and make an addition if you like it. Or Shai is very happy because he sells the next 2 stents and you waste money. But you have to recommend it, start higher, go more down. This is possible, but from down to up to go, it's not recommended and is no good way. Only in case if you go undergrad from the kidney, then you have to change your view. Then you start here and you go in the other direction, but you can't press it then in the deep one. Every time only one direction to make a reposition, but not to go up. No forward, only backward. Every time back, go forward.
Someone asked here, on average, how long to leave the stent, and what do you leave the stent for longer than 3 years?
We leave also the stent for longer than 3 years. The only control check or follow up what we do is, and what we recommended also in the report is, to make ultrasound check. In ultrasound, you see it. If you have a hydronephrosis developed, then you have an obstruction. This is the reason to replace. Or in case if you have a bad retention laboratory figures, then you can have also to change the stent. Otherwise, you can leave it. In X-ray, you see it exact also if a stone building is, but the stone building is then inside of the stent. So you bring the stent with the stone out, it is no problem then to make a next stent again.
Someone asked if you have any experience with retroperitoneal fibrosis.
Yes, we analyze now also the cases from the retroperitoneal stenosis. We have over 14 cases with retroperitoneal stenosis. In these cases, you have to leave it inside. And the problem is, it is really problematic then to make the dilatation because it's really strong. We dilated in these cases to 14 Shire, and the most of these ladies were patients where we done it, they leave the stent then to 2 to 3 years, and they are better one because that patients get before a lot of double G stents changing before, and with a ion stent, the mean time in these cases are 2 to 3 years, and then we change it.
Okay, we have a test again, like last time. Quick quiz of 10 questions. And we put it the link on the chat. Please go in and answer, and then send it to me. We can go through together.
Just 1 second about the quiz, and thank you, Dr. Neymeyer. We will go over the quiz together. As part of the seminar, we will have a quiz or a test for each one of the classes, persons, physicians, urologists or radiologists that will answer the test. They are relatively simple, but we'll answer the 4 classes that we will have that can get a certificate from the Charité Hospital saying that they passed 1, 2, 3, 4, and the knowledge, they have the knowledge and the ability to use our product. So we do recommend you to fill them and send them to us. We will gather everything and then send you the certification. We will go over now, Doron will go over with you on the test. You can ask questions. If the test questions are raising other questions, please ask us. Let's go, Doron.
Yeah. Okay, so you see that I share the screen?
Yeah, we can.
Okay, so first of all, what is the approval in dwelling time for Allium stent? You can enter your answer on the chat box. Okay, it's 3 years.
But it's not 3 and 3 years, Doron, as it indicated. So
3 is the number of the question.
Okay.
I see. Yes.
For which indication URS does not fit? Okay.
Doron, please clean the annotation.
I cannot do it.
Never mind, leave it for now.
Okay, so this is number 3, BPH. It's for prostate. Number 3, if the patient has malignant tumor present on the ureter, the doctor should, 1, not dilate the ureter, 2, wait 3 minutes, 3, dilate using balloon or rigid dilators, 4, locate the stent below the stricture. Okay, so it's number 3. After deployment of the stent, if reposition is needed, the doctor should, 1, repositioning is not recommended, 2, wait few days, 3, pull or push the stent using grasper or balloon, 4, put another stent.
Doron, let's discuss this question for a second. As Dr. Neymeyer said, pulling backwards the stent is relatively easy and can be done. Bringing it up is complicated and in most cases cannot be done more than, let's say, half a centimeter or something like that. And this is only if you do it just right after you deployed the stents and it did not open fully and the radial force is not already in full force. This is a bit complicated, and again, for physicians that are doing this for just for the beginning, it is rather, or it is better to take it out, and not just because I'm going to be happy, to take it out and put a new stent, and not to try to pull it up.
So that's why we recommend, and Dr. Neymeyer talked about it, you should open the stent a little bit up, and then if you need, so it's very easy to take the stent a little bit down. So the answer here is number 3. Question number 5, during removal, the stent cannot be removed, 2, slide and sometimes unravel, 3, always unravel. Yeah, it's number 2. Question number 6, if the stricture is in the UPJ, the retropelvic junction, the best option is 1, any stent with an anchor, 2, without anchor, length 100 or 120 millimeter, number 3, without anchor, 200 millimeter length, 4, all of the above. The answer here, number 3, the 20 centimeter stent is longer and has much more radial force.
Let's talk about that for a second too. Doron, just take it up.
Yeah.
well, before we had the 200 millimeters, then 120 were used. Since you have the junction is getting wider when you go to the kidney, as the longer the stent will be, the more radial force it will have and a more friction along the way, and then the possibility or the chances for it to move reduces. So we recommend to use in the UPJ 20 millimeters.
20 centimeters. Number 7, when dilating using 15 French balloon, the recommended length of the balloon, the best option should be 10 centimeter to 6 centimeter, 4 centimeter, it doesn't matter. Yeah, it's number 1, 10 centimeter. Usually if you if it's 10 centimeter, you can save a lot of time in one dilation instead of 2 or 3. Number 8, the soft edges at the end of the stent are designed to reduce 1, migration, 2, vesico-ureteral reflux, 3, irritation of the tissue, 4, answer 1 and 2. So the answer is,
So
I guess
we discussed that.
we have a mistake here.
Yeah. So most of you wrote 3. 3 is okay. This is right. This is actually a tricky question. The reason why the reflux is being prevented, this is only when you place the soft edges at the ostium, so or near the ostium. So if you place it near the ostium will close and functional as it should normally, and then it will close the long edges of the stent, and then the chances for reflux are reduced. But other than that, the main feature is that it will reduce the hyperplasia wherever you will place the stent.
La sonda, funciona bien el lavado.
Okay. Number 9.
Y funciona bien el lavado.
אתה עושה את הנוטיישן כל הזמן.
Vale. Pues entonces, ¿qué de analgesia que le estás poniendo?
אל תיגע במסך, כל פעם שאתה...
Okay, number 9, after deployment of the stent, the doctor should 1, pull out the delivery device, 2, pull out the guide wire, 3, wait 3 minutes to let the stent expand, 4, flush with construct media. Okay, it's number 3. And the last question, using antegrade approach, the anchor should be located in, okay, using antegrade, we are coming from the kidney. So the anchor should be always in the bladder. So it doesn't matter if we go through the antegrade or retrograde, anchor should be placed always in the bladder. This is the final screen. You need to fill in your details, email name, and your occupation, country, and send me the answers. And then after 4 classes of the webinars, we will send you the certification with the cooperation of Charité from Berlin. Okay. So everyone, thank you very much. It was a big pleasure with you again. And
thank you. Gracias.
Thank you.
See you next time. Our next webinar will be on May 7th. We will send you the invitation. Thank you very much. Hola, Pedro.
Con el ingeniero no. Solo con el ingeniero no. Esta. Creo que fue noviari. Cuando hubo el decano.
שומע?
כן, אני שומע.
שמו לנו מוזיקה ברקע.
Thank you very much, Dr. Neymeyer.
Thank you very much.
We'll call you again.
Thank you very much.
Thank you, all of you. Have a good weekend. See you next time on May 7th.
Yeah, thank you very much. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.